All right, welcome everybody. I'm going to give a few more seconds for people to join us. All right, welcome everybody. Thank you so much for joining us today. I am Bonnie Lynn Sweenor. I'm the director of the Johns Hopkins Disability Health Research Center. And I'm really grateful for those of you who are taking time to be with us today. I am a disabled middle-aged white woman with blonde shoulder-length hair. I use she, her pronouns. And today I'm in my office in Baltimore and respectfully acknowledge and give thanks to the Piscataway tribe, who are the indigenous people who are the traditional owners of this land. And I want to warmly welcome everyone to the third installment of our 2023 Disability and Public Health Seminar Series. I'm really so excited for our guest today, Yomi Rong, to discuss the intersection of racism and ableism in healthcare. Public health, as many of you who are joining us know, is recentering, importantly, on the communities that we serve. And Yomi is bringing to us today combined personal and professional perspectives in which we need to guide and use as a recentering moment for the work that we're doing moving forward in public health. As a reminder, and for those who are new to the seminar series, this is a joint effort with the Johns Hopkins Disability Health Research Center and the Johns Hopkins Bloomberg School of Public Health. The goal of this series is to better connect disability justice to public health by learning from the disability community, from activists, scholars, policymakers, and overall change makers. Many thanks to my co-lead for the series in this course, Dr. Jennifer Deal, as well as Dr. Franz Castro, Mindy Demchowski, Caroline Sorelli, who are assisting with this seminar series in the course, and thanks to our captioners, Laura, and our ASL interpreters, Kristen and Paula. Next slide. So just a few rules of the road for today's session. After Yomi is presenting, and then she and I will have some discussion, we will open it up to questions from the audience. Please use the chat function to type in your questions. Your messages will be sent to us and then will be read out loud by Dr. Franz Castro, who's monitoring this session. We have closed captioning today, which has been added to the chat. CART services can be utilized either through the Zoom CC button at the bottom or through the stream link that's in the chat. The seminar is being recorded for awareness. And if at any time you experience technical difficulties or have access needs, please contact Mindy at epitts4@jhmi.edu. Next slide. And just a quick note to join us right here next week. The last of our seminar series will be next Thursday, same time, same place. And we will be speaking with Dennis Newman Griffiths, and they will be talking about lived experience of with disability data, learning at the nexus of disability data and artificial intelligence. Sure to be a great discussion. Hope you'll come back and join us. Next slide. And without further ado, I'm really excited to introduce formally today's guest. Yomi Sachiko Rong is an Oakland, California-based consultant, trainer, and disability justice dreamer whose professional role in healthcare compliance centers access and equity for people with disabilities. This aligns with her political activism and community organizing, which she wholeheartedly commits in service of justice and liberation for all disabled body minds. As a former newspaper writer, Yomi occasionally pens about her own lived experiences, and you can check out her latest piece for Orion Magazine, which we're going to put that link in the chat in just a few seconds. And with that, I am going to turn it over to our guest to take us through some discussion. Thanks so much.
Thank you, Bonnie. Hi, everybody. Thank you, Bonnie. And I want to thank everybody for taking time out of their day to join this discussion. I promise not to talk at you for too long, but I do have a PowerPoint slide that I think will help frame the discussion. I want to be able to level set some definitions and frameworks and my positionality. And I think that would be helpful so that we're all kind of starting with the same set of information. And again, this is just going to be an overview and some level setting. It's, this is a topic that, we could have, years long class. And, we would not be doing service to the important issue of ableism in medicine by saying, oh, we went to this webinar, we heard Yomi or whoever speak for an hour, and now we get it. That's not how political education works. That's not how we build analysis, but it is a start. And so I appreciate Bonnie and everybody associated with Johns Hopkins for inviting me into this space. Next slide. So I'd like to talk briefly about my positionality. And so positionality in this context is the social and political context that creates my identity and how my identity influences my perceptions and outlook and even my biases of the world. So I should, because my academic advisor is here, I just want to name up front that I am a public health scholar. I returned to school in my ripe middle age of 50 after I lost my father to complications from long COVID. And I pursued a degree in public health equity. And it's really changed the trajectory, I think, of my career and my organizing work. Other things that you should know about me, how I identify: I'm a Black, disabled, female. I use she, her pronouns. I am a beloved daughter, sister, friend. I am a mama to a beautiful 9-month-old baby. And the lens that I understand this problem is as a healthcare professional, an activist, a community organizer, and as Bonnie said, a disability justice dreamer. Next slide. So what we're going to do today, before Bonnie and I get into the discussion, which I know will be juicy, and it's my favorite part, is to just give some definition of ableism, do a brief overview of the disability community that we're talking about and the health disparities, some of the health disparities and issues that our community deals with, and then just kind of get into exploring how ableism and systemic disabled oppression flourishes in medicine. Next slide. I think it's helpful for us to have a working definition of ableism from the perspective of folks who are closest to experiencing oppression. This is not a watered down definition. This is a liberatory definition. It is political and it is developed in community, and it is the definition that I use because I think that it's most appropriate to anti-oppression work and social justice organizing. Next slide. So the definition of ableism that I use in all of my political education and teaching and education work, and that I use to build and refine my analysis, is the working definition offered to us by Talila Lewis. It's updated almost annually. It's a working definition, and Talila developed this definition of ableism in community with disabled Black and negatively racialized folks. And I will just read it to you. Ableism, a system of assigning value to people's bodies and minds based on societally constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. This systemic oppression leads to people and society determining people's value based on their culture, age, language, appearance, religion, birth, or living place, notions of health or wellness, and or their ability to satisfactorily produce, reproduce, excel, and behave. You do not have to be disabled to experience ableism. And I'm just gonna let y'all swirl that around in your heads for a minute. And I wanna just say, actions don't need to be intentional to constitute ableism. It is a insidious form of implicit bias. It can be unconscious or unintended, but it perpetuates harms and it has a negative impact on people and environments. Next slide, please. There are many forms of ableism. For example, there is internalized ableism. There is interpersonal ableism. Today, we're going to be focusing on talking about institutional or structural ableism. And it's really about the way our society is built upon these harmful norms. So an example of institutional ableism is medical ableism, which is rooted in the idea that disability of any kind is a problem that needs fixing. Next slide, please. So who does this impact in the context of this discussion? We're talking about the disability community. Next slide. And the disability community is actually quite large. And it is estimated that 1 in 4 adults, or 20% of the population, have a disability. This is a significant conservative number. It's definitely an undercount. It does not count those who are institutionalized. It does not account for children. We are the largest minority group in this country. And we are the minority group that anybody can join at any time, actually. Next slide, please. In terms of prevalence of disability, so to put that 1 in 4 into real numbers, we're looking conservatively again at 61 million persons. Among young adults, cognitive disabilities are the most prevalent type. Mobility disability is most prevalent in middle age and among older adults. And disability prevalences are higher among women, among American Indians and Alaska Natives, and among adults with income below the federal poverty level and persons living in the US South. Before we move on to the next slide, I just want to say disability is part of human diversity. It transcends all races, all ethnicities, all socioeconomic status. Disability is everywhere, in every community, in every family. Next slide. I'd like to talk briefly about determinants of health. So determinants of health are a range of factors that influence the health status of individuals and populations. At every stage of life, health is determined by complex interactions between social and economic factors, the physical environment, and individual behavior. They do not exist in isolation. Persons with disabilities confront numerous disadvantages from social environmental determinants of health, including, but not limited to, lower educational levels, lower incomes, and higher rates of unemployment. Next slide. For those of you who like graphs, you can see from this graph that what jumps out at me immediately is that adults with disabilities in the United States are more likely to have depression. We are more likely to be overweight or obese. We are more likely to engage in risky health behaviors such as smoking. We are more likely to have chronic disease such as diabetes and heart disease. Persons with disabilities face lower rates of preventative screenings and more difficulty accessing health services. Next slide, please. What this amounts to is just really crappy patient experiences. in narratives shared by individuals with disabilities, in all of the areas where I work and organize. The common theme is discriminatory and dehumanizing healthcare-related experiences. Why might that be? Next slide, please. Ableism. Ableism is the bane of our existence, and it flourishes in medicine. Next slide. Remember what we said earlier about ableism. Ableism values independence over interdependence and perceives physical capability, able-bodiedness, and neurotypicality as the norm. Next slide, please. And then hold that definition of ableism, hold the definition, hold how it resonates with you, maybe personally, or in your own family or in your life, in your work. And then now consider this. Many clinicians hold misconceptions about and strong negative biases toward people with disabilities. Next slide. And I'm not making this up. Dr. Lisa Iazzoni led a really important study that was published in 2021, where she and colleagues surveyed outpatient physicians about their attitudes toward patients with disabilities. And 80%, actually more than 80%, believe that people with significant disabilities, so that would be me, have a worse quality of life than those who are not disabled. So these are people who are charged with rendering care and developing trusting relationships with their patients. And from the gate, they believe that people with significant disabilities have a poor quality of life without even knowing the person. Next slide. This survey revealed rampant ignorance among medical providers. For example, 35% of these physicians said that they knew little or nothing about their legal obligations under federal disability access law, so under the Americans with Disabilities Act, that they are beholden to, that they have an obligation to uphold, especially if they are receiving federal dollars such as Medi-Cal, Medicare, Medicaid. So you had a percentage that knows little or nothing about their legal obligations, and then a really high percentage felt that they were at risk of being sued for violating the ADA. So they are ignorant of the law, and they also fear the law because they're ignorant about it. And they have a perception that people with disabilities just go around suing everybody, and that the law itself is burdensome. Additionally, many of these providers surveyed felt that they were inadequately reimbursed for providing accommodations to patients with disabilities. Some physicians reported that because of these concerns, they attempted to discharge people with disabilities from their practices. So they're ignorant of the law, they fear the law, they have anger, frustration, whatever, that they don't feel that they are adequately reimbursed from either patients or payers for providing accommodations that they are obligated to provide under the law. And for this reason, they actively obstruct care relationships by trying to get sick and disabled people booted from their practices. And this is in their own words. Next slide. So you can imagine the impact on all of us who are patients, all of us who are sick, chronically ill, and disabled, confronting this level of ignorance, discriminatory practices, provider bias. The impact on the patients is you have providers medical offices that are very reluctant to provide accommodations, such as interpreters for patients who are deaf and need interpreters. Appropriate medical equipment so that people with disabilities can receive the same standard of care as non-disabled patients. This gets baked into discriminatory policies and practices, so that's the systemic part of the oppression. And then patients are just dealing constantly with a lack of disability, cultural understanding, and humility among providers. So that's the end of the lecture portion. I'm going to stop there and invite Bonnie back in to join me in conversation. I've said a mouthful.
This is Bonnie. Well, thank you so much. I think it's always so important to learn from people with lived experience, and you have this combination of lived experience and professional experience as well. And so just thank you so much for sharing that. And before I dive into ask you questions, as someone that's very data focused, I always find it so important and interesting of how the same data can be interpreted with such different meaning when this is your life, right? When this is your experience. So anyway, so just thanks for taking time to share that with us. So I wanted to start out with the questions by asking you to share with the audience why ableism is an issue that society, and in particular, why public health professionals shouldn't be concerned about. I mean, you've described it, but really, why now? Like, why should
anybody care?
Yeah.
Well, I mean, I think, and I'm going to speak now as if I'm talking to public health professionals, right? And I know that there are other people with different backgrounds who are tuning in. We know that health is influenced by many factors, including and especially the economic and social conditions of communities. So addressing social determinants of health, which is the business of public health professionals, is a primary approach to achieving health equity. And by health equity, I'm not saying that everybody lives to be a ripe old age of 103 and never gets sick. Health equity is really about supporting communities and individuals to achieve their maximum optimal level of good health. And so in order to do that, we have to dismantle all systems of oppression, including ableism and especially ableism, to help people thrive. So that's why this concerns public health.
Yeah, exactly. And I love that focus on thriving. That's it exactly, I believe too. So the title of this session of your discussion is Understanding How Implicit Bias and Disabled Oppression Contribute to Health Disparities. So let's now talk a little bit more about that link, the link between disability bias, oppression of disabled people, and health disparities. Again, you've reviewed some of this in the slides you shared, but just a little more discussion about what do you mean about this linkage? Why are these things so linked? And again, speaking to a group of public health professionals.
Yeah, so I think one way to really understand the linkage is to take an intersectional lens, right? And so intersectionality is such a beautiful and useful framework for understanding the way people's multiple identities and various forms of oppression combine and collide and impact people's lives. So I will give one example of the ways that disabled oppression in the medical field, and I would say in the healthcare field writ large, contributes to disparities. There is a tremendous amount of gatekeeping around, for instance, durable medical equipment. And this is just wheelchairs, walkers, ventilators, hearing aids, anything that people need to be able to function, because disability, what we're really talking about is function. We want to support people to be able to function in life independently, autonomously. And when I say independence, I don't mean we do everything ourselves. It means that we are in charge of how things are done. And yet there is a tremendous amount of really obnoxious and oppressive gatekeeping, starting with payers around limiting how much people, how much can be spent on wheelchairs, for instance. I think that payers think that all bodies are the same, and that, just giving all of us like the 1970 Everton Jennings clanky wheelchair, a metal wheelchair, should be fine. And that's not the case. We have unique bodies. Some of us need dynamic seating and positioning in our mobility devices. And yet we have to jump through so many hoops to prove medical necessity. We first have to go to our providers, so some of these same clinicians who really wish that we weren't their patients, and get them to write a prescription and make the case for why we need these devices. So the gatekeeping starts there, and then we have to go through insurance providers and payers that often want to limit these benefits or deny them altogether. And then in the meantime, some of us are developing secondary conditions, injuries, all of these things, because we're not in devices that fit our bodies and that support our bodies. And so things just become exacerbated. This leads to further negative health outcomes, and it just worsens. Things just worsen over time. That is a small example of disabled oppression and how it shows up in the field of health.
Yeah, thank you. I mean, a critical example, and I think really shows how disabled people are almost collateral damage in this cycle, in this process, and just how devalued our lives are in the system. That's a very takes your breath away kind of an example, and one.
It should anger you, it should piss us off. Right?
Yes, it does. Yes, it should, right? And I think, these conversations and these dialogues just haven't happened enough in these spaces to shine light on that, right? Put some light on these experiences. And I'm sure you and I could talk for too long about why that is. But
Bonnie, and you and I were talking the other day, and you were telling me how the NIH, National Institutes of Health, just very recently, like I think a week ago, held their very first symposium on ableism. I mean, hello, we are more than 30 years past the Americans with Disabilities Act, and people are just now starting to talk about ableism. This is not a new concept. And so it is both shameful that this conversation is just happening now. I have so many questions, like who was there, who was invited into the table, was there leadership of those most impacted by multiple systems of oppression that were part of the conversation. And I hold some hope that we are finally having these conversations.
Yeah, yes, yes. It is sort of that, double-edged sword feeling.
Yeah, I mean, I don't think we should be patting ourselves on the back.
Yeah.
Nobody at NIH should be patting themselves on the back about this. We just say we have work to do, and shame on us for just getting started.
Yeah. So with this audience of public health professionals that paying attention now in this moment, and hopefully paying close attention to everything you're saying, what do you wish that public health professionals would learn or even knew about this interconnection of ableism in medicine and healthcare, even in public health? What do you really want them to know, and for them to go out and share with their colleagues? Yeah,
thank you for that. So I want to talk about maybe a path forward and what I think people should know. So, I'm a health nerd, a public health nerd, a bit of a wonk. I think you are too. You might remember that, I think it was something like 20 years ago, Brian Smedley, who was a health equity researcher at the Urban Institute, was the lead author, editor of a report called Unequal Treatment. And it was a landmark report that examined health disparities in the United States, right? And this was the first major report to point to longstanding systemic racism as a major reason for the nation's deeply entrenched health disparities. So racism, not poverty, not lack of access to healthcare or other social factors. And yet little has changed. right? So the path forward, and this might sound weird or radical to some people, and I'm not the only one talking about it, is like we need restorative justice in medicine. We need deep analysis of ableism and the ways that it harms communities. We need policies and procedures that act as guardrails to protect sick and disabled people from having to constantly deal with ableist systems and practices and discriminatory systems and practices and attitudes in the medical setting. So, because these guardrails are the only thing that are going to help people not fall off the cliff, right? That health cliff that those of us in public health know about, right? All of the levels where we can actually capture people and try to help them thrive in their lives. And I think that the onus is not on the sick and disabled person. We do enough labor in our lives of navigating these systems and educating. We do so much social management of our disabilities and our conditions in our interpersonal relationships and in relationships out in the world, even with our medical providers, that like we're tired. And we shouldn't have to do this labor as patients. The onus should be on people who are in positions of power and privilege. And in this case, medical professionals, researchers, faculty heads, department heads, decision makers. We all have a duty to do all that we can to address these disparities and inequities. And the only way to address it is to understand it, and that is to build our analysis and commit ourselves to anti-oppression work in the same way that people allegedly are committing themselves to anti-racism work right now. Because these are bedfellows. Ableism, racism, sexism, ageism, all of that is entrenched and upheld by white supremacy, capitalism, colonialism. We need to decolonize our medical system in order to help people thrive. And so, yeah, it's doing the work to build the analysis. And I think a helpful way to do that is to apply that intersectional approach to the issue, because it takes into account the historical, social, and political context of people's lives. And it seeks to understand the unique experience of the individual who faces discrimination and oppression on multiple grounds based on our overlapping identities. To say more, people with disabilities, and the research shows this, are members who are members of racialized groups are more likely to be unemployed or underemployed. And so people with disabilities who are members of racialized groups may be doubly disadvantaged. So that's that connection between racism and ableism. Women with disabilities, for example, experience additional disadvantage as a result of the intersection of disability with gender. Gender nonconforming people and folks who are not neurotypical experience multiple forms of oppression and disadvantage based on those intersects. I'll stop there. I feel like I'm just.
Yeah, no,
Yeah.
I mean, that's so important. You know, I have so much thoughts in my head, you know, just to start, I so much value your comment about restorative justice, and, you know, it strikes me that in these kinds of spaces in public health and medicine, you know, it takes for us to even get to a place where our history is even documented, talked about, right? To understand the harms that have been done. And, you know, I think too often, to your point, the view is that the disability community has to do that work. And I think that we need to really push on that, because so often people, you know, will say there's just a lack of this history, right? I mean, in the places where they are learning, and we've got to change that structure and do so in a way that has centered on the community perspectives, but is exactly right, is not saying this is your job to solve. And your point about, an anti-oppression framework is so, hits home. I have the privilege and opportunity to be in so many spaces talking about health equity, and it is so interesting in how we have become so myopic in these approaches like you're describing, and that's at a cost to our society across the board. And I think that is what the future exactly has to be, is that full intersectional approach and full anti-oppression approach. It's been it's tough right now, and I think that yeah, we need more hearing from folks like you, and as you described, the cycle is so linked with keeping folks out that have those experiences from these places. And so, we've got to figure out got to disrupt
and
it.
I just, and I also think so we have such a rich laboratory that we are living through right now, which is the COVID-19 pandemic, which is not over, by the way, CDC, if you're watching. The pandemic's not over. This has been a mass death and disabling event. People are still dying in very large numbers. Sick and disabled people, those who are have compromised immune systems or who chronic health conditions, and who are otherwise vulnerable and susceptible to illness and death from this virus, still have to take precautions. And yet our lives are treated as acceptable losses. I am not okay with that. So if you just look at who bore the brunt of COVID-19 illness and death, it is Black, Brown, and Indigenous communities. It is poor communities. It is sick and disabled folks. It is our elders. We don't need, if I never speak to another group of providers or public health colleagues again, you could just look at the data. The data is there. And we clutch our pearls and wring our hands in public health about why won't people listen to public health messaging? Why don't people just do like the least and wear a mask or social distance, or I don't know, take this shot in the arm? It's because we have lost our credibility with marginalized communities. We have lost our credibility. You cannot oppress me and fail to see my humanity and not believe my symptoms and gatekeep equitable healthcare and not attend to my social needs and supports for my entire life, experiment on my community, inject us with syphilis to see what happens, sterilize our mothers and our daughters. You can't do that to people. And then when the what hits the fan and you say, take this shot, and people say, yeah, I don't know. I don't know if I believe you. Wonder why we're not believed. There is a reckoning. And we've seen that reckoning unfold over the last 3 years. And this reckoning is squarely the fault, and I lay it at the feet of the medical community and public health professionals that have done a really poor job of understanding the communities they serve, meeting people where they are at, and figuring out how to have conducive therapeutic relationships with the people we claim to care about.
Yes. So exactly. No, I mean,
You got me going.
I know, I'm like getting emotional. It's very powerful, Lisa.
Okay.
I appreciate it. And we need to keep saying it, I think, until it changes, which is painful to do.
Yeah.
So thank you for doing
Yeah,
that.
and I think also, part of the issue is around, we can attack it at multiple fronts, right? There's political education, there's doing anti-oppression work, it's all of that. So I say all of that and I paint this very grim picture because it is grim, right? People's lives are on the line. People are struggling to get equitable health care, to feel seen and heard by medical providers. At the same time, I work inside healthcare. I'm a clinical operations leader inside a large healthcare organization. And I can tell you that for every shitty doctor out there, there are 10 more who deeply care and deeply want to get this right. And if they are just getting the tools and the education and the analysis, they will do better. They will meet their patients' needs. They want to. They don't want to perpetuate harm. They don't want to do harm. They just need to understand how not to. So
Yeah.
that gives me hope.
Yeah, yes, that is an important message. And yes, it's that grim reality with the hope of, human beings, of giving room for change and opportunity for everyone.
Yeah.
So I know we have some questions mounting in the
Okay.
chat. I know we had one more question about actions, but if it's okay, could we pivot to these great questions from the audience?
Yeah, sure.
Okay.
Yeah.
So I'm going to turn it over to Dr. Franz Castro, who works in the Disability Health Research Center, is going to curate and read out loud some of these great questions, but I see you mounting up and they're really, really excellent. So Franz, if you're ready, I'm going to turn it to you to read some questions.
Thank you, Bonnie. There are great questions in the chat. The first question is related to implicit bias in healthcare. Are you seeing ageism and ableism colliding? And do you believe that this translates into less equal access to quality healthcare for older adults?
Yes, yes, and yes. Yes. So think about all forms of oppression and all your isms: racism, sexism, all your phobias, transphobia, sexism, ageism. I don't know if I went through all the isms, ableism, all of that intersects. All of that is a problem. We are a country that is aging. Most of us, if we live long enough, are going to acquire disabilities and impairment. And we're suddenly going to go from being the easy patient that just goes in for, annual physicals or when we have an injury that then's going to heal, to patients that have complex needs and who are going to require a higher touch. And so will systems and the people who run these systems be ready to meet that need? And I have concerns. I mean, I said I switched the focus of my healthcare career and, went back to school at age 50 just so that I could focus on public health and public health equity. And it's because I saw the way my father was treated when he got COVID in Arizona. I saw his struggle getting care. As an inpatient, I saw him get booted from an ICU and sent home to die. We struggled to have care for him at home. He developed long COVID. He languished for 4 months, and then he died. My father is a World War II veteran, and the VA did not help him. It was just, we don't care for our elders. We don't care for vulnerable communities. We don't care for marginalized folks in the way that we should. And so I took on a whole lot of new school debt so that I could better understand this issue from the inside and hopefully make a difference so that my father's death would not be in vain.
Thank you for your response. Absolutely, oppression in healthcare and exclusion of people with disabilities and people with intersecting identities is an issue that affects us all. And it is really important to push this idea forward. The next question is related to power structures and ableism. what do you think is the most helpful corrective attitude or action that can be taken by lay people who might not be in the medical power structure, but that can certainly be prone to unthinking ableism?
I'd say do your work, do some political education. Don't ask your disabled loved ones and friends always to educate you. The same what we say in doing anti-racist work for white folks, right? Talk amongst yourself, do the work. There are so many resources out there for you to start unlearning implicit behavior and biases, things that you might not even be conscious of. Think about, your perception of what makes a good body. What do good bodies look like to you? Is it a fat body? Is it a small body like mine? Is it a black body? Is it a gnarled and twisted body? And why do you feel that way? I would say just start doing the work to unpack whatever biases you might have, and it will make you a better ally. And if you're really lucky, you get to be an accomplice in dismantling these systems. But I would say start with educating yourself and really being reflective about the able privilege that you might hold and the ways that you too are impacted by ableism. Because as I said in the definition, you don't have to be disabled to be impacted by ableism. Your body might be perceived by some as not a good body. And how does that feel? How does it impact you and how you move through the world?
Thank you. We have a follow-up question on medical education and bias. At what point do you think medical or healthcare providers develop these implicit biases? Is it during their pre-professional education, during their professional education, or during their professional practices?
I think we develop bias from birth, right? We develop bias from messaging, narratives and practices in our families, in our communities. We start to develop implicit bias very early on. We carry these notions and prejudices and biases with us throughout life if something doesn't happen to disrupt them, right? We might have a personal experience that then changes our view. So we enter whatever professional fields or educational endeavors with so much baggage already, right? With narratives in our head, scripts, social scripts about the other. So it starts way before we get into school. And then it's not helped, I think, in medical school because I don't know. I mean, are there preceptor courses that help rising clinicians address implicit bias, address racism, ableism, sexism that lives and thrives in their own little hearts and shapes their view of the world? And then impacts their interactions with their patients. I'll tell you, I did a talk on ableism in medicine for a medical school, and I won't name this school. And we were talking about recruitment, right? So there's so many ways that we can get at this. One, we need more people with disabilities who are clinicians, who are in the field of public health. And I think that they're out there, but they might have disabilities that they're hiding, that they don't feel comfortable being public about, or they might not have a political identity as a disabled person, which is very important. And there was a question from somebody who was a clinician, and this person said that they had a colleague, so another doctor, who was seeing patients, and this colleague was clearly disabled, had a significant physical disability. And they worried about this colleague. They were so curious. Is this colleague providing the right standard of care? How are they interacting with their patients? They had so many questions and curiosities and concerns about whether their colleague that they see every day, who has their own patients on their panel, whether their colleague was up to the job. And they said, what should I do about that? How do I approach this? And I said, mind your business. Why would you assume that your disabled colleague can't do their job. And you've been holding on to this thought and curiosity and concern about this person for however many years that you've worked alongside them. And it's really clouding your view and your judgment of them. You know nothing to the contrary. There haven't been complaints from patients. You haven't heard that this person can't provide the same standard of care or can't do their job. And yet you see this person come to work every single day and do what you do. And somehow you still wonder if they're fit to be a doctor. And so, I mean, I think that these schools, these teaching institutions have a duty when we know that this systemic oppression is really like a cancer that has infected medicine for many years or generations. We have a duty to try to cure it, to try to fix it, to stamp it out, to eradicate it. And I think medical schools, I can't speak for all of them, but I think a lot of them are doing a really crappy job of preparing providers to actually be in the real world and deal with patients from a variety of backgrounds and who present a variety of different bodies and conditions to them.
Absolutely. These implicit biases are perpetuated by the way the medical education system works. And there is a need also of shifting the societal understanding of not only ableism, but also all other types of implicit biases. So now let's talk about change. Have you seen any good examples of medical systems who have great training for medical staff on access or accommodations?
Yeah, I think there definitely is systems change happening. I am part of a national kind of cohort of folks who do the work that I do, which is more of like a disability compliance role, who are really focused on health equity, because we know that, you know, policies and procedures are one thing. People do need to be trained to policies and procedures, but we also got to get in there and change hearts and minds. We also have to understand disparities so that we can mitigate them. So there are people doing really good work around the country inside healthcare systems to try to shift things. I don't know of a specific training for medical providers, but I do know that I can speak for what I do. Whenever I have the privilege and opportunity to have a conversation or have an audience with our clinicians, they're so busy. They work so hard. And so it's like precious when you get focused time with them. I talk about disparities because that's something they can understand. That's something they're passionate about. I talk about health disparities and what we can do to mitigate them. And I do talk about ableism. I do talk about the importance of accommodations. And I think that there are other people, not enough, but there are people who are like-minded and have this analysis sprinkled throughout the country that are also trying to do this work inside healthcare systems. There's not enough of us, I can tell you that. And there aren't enough of them, frankly, that look like me, right? Disability justice principle is that, you know, it's leadership of those most impacted. We really need to have people at all levels of medicine and public health teaching, who are practitioners, who are clinicians, who are developing policy, who have lived experience, who have the combination of the lived experience, the correct political analysis, and the educational background or the work experience or professional acumen, whatever you want to call it, to bring credibility to this messaging and to help shift.
Thank you for your answer. Those are great points. There is a need to continue having these conversations where not only healthcare professionals are involved, but also the most important stakeholders, members of the disability community. We have another question about education. As a student, do you have recommendations for how to interact with faculty who might be perpetuating isms like ableism? How can we cure these biases and oppressions given the kind of power dynamic there?
I would say recognize your power as a scholar. You are paying these people to educate you. Okay, so first of all, trust your instinct. You know when you're experiencing oppression. You know when you're being oppressed. You know when somebody's using ableist language or racist language. Call it out. Call them on the floor. Call them in, call them out, depending on your relationship with them. But I'd say you need to call it out. Call it out and then call them in and invite them to new understanding, to unlearn what they think they know. They're there to serve you. They're there to educate you. You're not there to serve them and their egos. Call it out. And keep calling it out.
That is a great point to really undo these power structures. It is important to be vocal and to speak up. There are no additional questions in the chat, so I'll turn it over to Bonnie, and thank you to all participants for their great questions.
Yeah, this is Bonnie. Thank you so much. There was a lot of praise, I will say, immense praise and request for the recording. So thank you so much, Yomi, for being with us and sharing your knowledge and your personal experience, which, as you described, is important and powerful. And we need all of us to work to make sure our work is centered on that. You know, I say, we say in my center that we make choices every day, all day, to either uphold or tear down the systems of power and oppression. And just to remind everyone in the audience that
always choose tear it down.
Yes, always choose tear it down.
Always.
That's right.
Always.
Hopefully.
Always swipe on tear it down. Tear it down.
Yeah. And but I just
recognize your power.
That's
like
right.
We might think that we hold no power as patients, as students, as scholars, or whatever, and that is so not true. There is so much power in collective action. There is so much power in community. So much power.
Yeah.
We take care of us.
Yeah. Yeah, I think that is a great message to end this conversation on. And
thank you for having me. I appreciate it.
No.
And I want to thank the folks for just spending time here. I glanced a little bit at the chat for your great questions, and just really want to thank my people. I see my people, some of my people are here. My family and close friends have joined in. And so I just appreciate everybody's attention and focus on this. And, you know, go forth into the world and do better. Ableism is trash. Get a t-shirt that says that. Wear it proudly.
Is. And use your power, right?
Use your power.
Yeah. Thank you so much. Thank you, everyone. Keep doing the work and join us here next week. And thanks again. Thanks, Yomi.